Hello to everyone from Geneva WHO headquarters. My name is Tariq and I welcome you to this regular COVID-19 press briefing. It's not so regular because today is International Migrants Day and Dr. Tedros will say more about that, as well as our guests. Before I give the floor to Dr. Tedros, just to remind journalists that this press briefing has simultaneous translation into 6 UN languages, plus Portuguese, plus Hindi. We will open the floor to questions immediately after opening remarks. We would ask journalists to be brief and ask one question at a time. I would also like to use this opportunity to thank our interpreters who are helping us with the interpretation for today. I will briefly say who is in the room here, and then I will also later announce who is online to answer any questions. In the room we have Dr. Tedros, WHO Director General. We have also our special guest that Dr. Tedros will introduce a little bit more in detail, but it is Mr. Antonio Vitorino, Director General of the International Organization for Migrations. We have Dr. Mike Ryan, who is our head of the emergency program. We have Dr. Maria Van Kerkhove, technical lead for COVID-19. We also have Ms. Jacqueline Vickers, who is director of Migration Health Division with IOM. And we have Dr. Santino Severoni, who is our Director WHO of Migration and Health. Bruce Aylward is also with us, who is working with ACT Accelerator. I'll give the floor to Dr. Tedros for his opening remarks, and then we will introduce other experts who are online with us.
Thank you, Tariq. Good morning, good afternoon, and good evening. On Monday, I ended our press conference by sending my best wishes to UNHCR, the UN Refugee Agency, for its 70th birthday. And today is International Migrants Day, and I'm delighted to be joined by Antonio Vitorino, Director General of the International Organization of Migration. Welcome, sir. IOM is our next-door neighbor here in Geneva and our very close partner. In recent years, we have witnessed the largest population movements and displacement since the end of the Second World War. Too often, migrants and their families remain outsiders in their adapted communities, even years after migrating. They face discrimination, social exclusion, and lack of access to health services. And yet, migrants make enormous contributions to our societies with new ideas that drive economic and social innovation. That's also true in the COVID-19 response. It was Turkish migrants to Germany who founded the company that developed the first COVID-19 vaccine to be approved and rolled out. And it was a nurse from the Philippines who administered the first dose of that vaccine in the UK. All around the world, many health workers are migrants, especially women, who account for 70% of the global health workforce. When the World Health Assembly designated 2020 as the International Year of the Nurse and the Midwife, none of us had any idea how much we would rely on nurses, midwives, and other health workers to keep us safe in the face of a global pandemic. We all owe a huge debt of gratitude to the nurses and midwives who are often the first and only health professionals present to treat and comfort the sick and dying and bring new life into the world. Together with Women in Global Health, the International Council of Nurses, the International Confederation of Midwives, the United Nations Population Fund, and Nursing Now, we yesterday launched a list of 100 outstanding women nurses and midwives from around the world who have made an exceptional contribution to nursing and midwifery. They represent millions of nurses and midwives who use their knowledge and expertise on a daily basis to protect the health and lives of others, at times putting themselves in harm's way to do so. To better understand the impacts of COVID-19 in refugee and migrant populations, WHO and a research consortium led by Ghent University and the University of Copenhagen has conducted a global survey called Apart Together. The survey was supported by several partners and included almost 30,000 migrants and refugees in almost all WHO member states. It shows that people living on the streets and in asylum centers are less likely to seek care if they have symptoms of COVID-19. Of those who reported not seeking health care, 35% said it was because of financial constraints, and a further 22% said it was fear of deportation. More than half of those surveyed said that COVID has caused them depression, worry, anxiety, and loneliness. These findings paint a bleak picture, but they also point the way forward. There are several measures countries can take to include refugees and migrants in response plans and public health measures. Access to care must not be linked to legal status. Improving internet access for migrants is also important for improving access to information. And most crucially, we call on all countries to remove financial and other barriers to care for migrants as part of their journey towards universal health coverage. Health for all means all, including migrants. That means increasing investments in health, especially in primary health care, to create health systems that are sensitive to migrants' needs, their language, and their health problems. These include reproductive and child health, mental health, trauma from injuries, violence, sexual abuse, and assault. Investing in the health of migrants is not just the right thing to do. It also has long-term benefits for social cohesion and economic development. Exclusion is costly in the long run, but inclusion pays off for everyone. It's also vital that migrants and refugees are included in plans for the rollout of vaccines against COVID-19. As you know, the ACT Accelerator, which includes the COVAX facility, was established to ensure access to vaccines for the world's poorest and most vulnerable people, many of whom are migrants. Earlier today, WHO and our COVAX partners, Gavi, CEPI, and UNICEF, announced that we have secured agreements to access 2 billion doses of several promising vaccine candidates. I would like to thank Canada and Prime Minister Trudeau for committing to share surplus doses of COVID-19 vaccines. These unprecedented agreements mean that all 190 countries and economies participating in COVAX will be able to access vaccines to protect vulnerable groups in their populations during the first half of next year. This week, I have spoken with CEOs of pharmaceutical companies and met with European Commission President Ursula and President Charles Michel in Brussels to ensure that we start vaccination as soon as possible in the new year. WHO and our COVAX partners are working non-stop to start vaccination as soon as possible in the new year. And WHO remains committed to working closely with IOM and many other partners to support countries in improving the health of migrants during the pandemic and after it's over. It's now my great pleasure to introduce Antonio Vitorino, Director General of the International Organization of Migration, to say a few words. Antonio? Fratello, mio fratello, you have the floor.
Thank you so much, Tedros. It's a great pleasure for me to be here today with you, not just as a neighbor, but as a close partner in International Migration Day. Because of all the reasons that you have just mentioned, it is indeed critical that we join forces to ensure that the most vulnerable, including, as you have said, migrants, refugees, asylum seekers, internally displaced persons, and in general people on the move, are not left out of our global efforts to fight back against COVID-19. I must say that contrary to the political rhetoric, most of these forcible displaced persons live in low and middle income countries, which tend to have weaker health systems and struggle to meet the health needs of their own population. Access to health, it's a human right. It's a human right of migrants too. But the list of barriers and difficulties that migrants face in accessing health care is far too long. That said, I believe that in some countries, being a regular migrant is a prerequisite to access to health care. But this leaves quite a large number of irregular migrants, stranded migrants, migrants that cannot return back home, and we estimate that we have 3 million stranded migrants all over the world, and leaves also migrants in detention uncovered. Too often, health information is not given in a language that is understood by migrants. And last but not least, as you have mentioned, migrants are particularly prone to anxiety, to insecurity, to mental health and psychosocial problems, and especially women and girls who are particularly vulnerable. And to be honest, what I have found particularly intolerable in this current crisis is that while being so often left behind, migrants have also been on the front line of the response to the pandemic, taking personal risks for everyone's well-being, and these across many critical sectors, not just the healthcare sector, but also transport, food, retail, research, hygiene, and home care, you name it. So I'm happy to be able to tell you that many countries have understood the importance of universal health coverage. Already before the pandemic, about 43% of all countries offered health coverage to all migrants, no matter their legal status. And in this year of public health emergency, several host countries have temporarily introduced new policies or relaxed requirements to grant access of migrants to health care. But this is not enough. One of the crucial issues is that migrants sometimes are suspicious to look for health care because they are afraid that contacting health services, they might be detained or even deported. Building a mutual trust relationship between public health services and migrants will be crucial, especially now, as we are going to have a true test case. As we collectively gear up for one of the world's largest vaccination campaigns, I believe that we must be vigilant and ensure that access to the vaccine is fair and equitable. I praise the efforts of WHO in the COVAX environment and the WHO partners, Gavi and the Vaccine Alliance on this front. And therefore I want to take this opportunity to call on governments to count and include all migrants present in their territory, no matter their legal status, in their national vaccination plans. And let me be very clear. As governments prioritize health workers on the front lines, they need to make sure that migrant frontline health workers are also vaccinated. And as governments prioritize people above a certain age, then all migrants about that same age should be prioritized in the same way. It's not a question of creating any preference or privilege to migrants. It's to guaranteeing access to the vaccination on equal foot as the nationals. It remains vital that migrants in vulnerable situations have access to immunization and essential primary health care services, including mental health, in humanitarian settings as much as in urban slums or border communities. From our side, Tedros, you can count on IOM engagement and support for the efforts to guarantee a successful vaccination process that we finally defeat the virus. Thank you.
Thank you, thank you so much, Antonio. So, Tariq, back to you.
Thank you very much, Mr. Vitorino and Dr. Tedros, for these opening remarks on this very important day. Before I start calling on journalists for questions, just to let you know that we have online also Dr. Soumya Swaminathan, who is the WHO Chief Scientist. We also have Kate O'Brien, Director for Immunization, and we have Mariangela Shimao, who is Assistant Director General for Access to health products and medicines. With that, I will start with the Philippines Daily, and we have Jovik Yi online with us, and I think it's the first time we have Jovik with us. Jovik, please unmute yourself.
Can you hear me?
Yes, please.
Hi. I just would like to ask about the public's preference over some candidate vaccines. Pfizer, Moderna, and AstraZeneca earlier released the efficacy data on their vaccines, which naturally excited everyone. But of course, these firms can't be expected to supply the entire world with their vaccine. So my question is, what can WHO say to those people who might be questioning or have doubts with their government's decision to acquire or enter into deals with manufacturers that have yet to release their data or are still completing their phase 3 trials? Thank you.
Thank you, Jovik. The line was not really the best. If we were able to hear, it's about candidate vaccines and data in particular about AstraZeneca vaccine. So if Dr. Swaminathan is online, maybe Dr. Swaminathan can try to answer this if Dr. Swaminathan, you heard the question correctly.
Thank you, Tariq. Actually, I couldn't hear the question very clearly. Is it possible to repeat it?
I think the question was about the data that we are getting from different manufacturers, and I think there was a question about AstraZeneca vaccine in particular. And Jovik, if I'm wrong, please correct me because we were not able to hear correctly.
Okay,
Hello.
so maybe I can try.
Can you hear me now?
Yes, please try again.
My question is about, I would like to ask about public's preference over some candidate vaccines, because Pfizer, Moderna, and AstraZeneca had already released their efficacy data. But of course, these firms can't be expected to supply the entire world with the vaccine. So my question is, what can WHO say to those people who might be questioning their government's decision to acquire or enter into deals with manufacturers that have yet to release their data or are still completing their phase 3 trials? Thank you.
Okay, I think that was clearer. So I can start, and Mary Angela or Kate might want to come in, or Mike. So the first thing I would like to say is that the WHO really wants to support as many vaccine candidates as possible to go through clinical trials. Because as you just pointed out, there are a number of different properties or characteristics of a vaccine that may make it more suitable or less suitable for different settings. Ideally, one would like to see a vaccine that's a single dose that can be stored at room temperature, that gives long-lasting protection, that's safe, effective, and is also, manufactured easily and can be scaled and is affordable. So that would be a really ideal vaccine. And there are so many candidates in development, including, innovative products like a combined influenza and SARS-CoV-2 vaccine. There's a measles platform. There's an intranasal vaccine, a couple of them that are coming along. So we would like to support the research and development, and we'd like to support companies and countries and encourage them to continue with clinical trials. So I think that's the first message. The second is about the question of when is a vaccine good enough to be used? And again, there are very clear criteria that we've laid down, that regulatory agencies like the FDA and the EMA have laid down. And these criteria have benchmarks for both efficacy as well as safety, as well as things like the quality of manufacturing, which needs to be checked before WHO or any of the regulatory agencies would endorse a vaccine, either through an emergency use listing or ultimately through a full licensure or a pre-qualification, as the case may be. So I think the criteria are clear. Now it's up to regulatory agencies and countries to make the decisions. And they make decisions based on benefits and risks. Because in a situation when you're in a pandemic, there's obviously an urgency and a need to get vaccines out to people. And therefore one has to weigh the benefits and the risks at a particular time. WHO will examine all the dossiers that are submitted to WHO. Mary Angela's division is accepting these on a rolling submission basis so that we are up to speed, we can move quickly, and we would provide either emergency use authorization or pre-qualification, as the case may be, based on the data that we are able to examine. Thank you, and maybe somebody else would like to add.
Thank you, Dr. Swaminathan. I understand Dr. O'Brien would like to add something. Dr. O'Brien?
Yeah, just very briefly. Countries, because of the supply situation, most countries are likely going to have to use more than one product. And so we do need multiple products in the marketplace. They do need to meet efficacy and safety and manufacturing standards. But most countries are going to have to be juggling more than one product, and getting that supply security is really important. So I think those are just elements from a delivery perspective that we also have to keep in mind. Thank you. Over.
Eric.
Thank you, Kate. I understand also Dr. Aylward and Dr. Mike Cran would like to add something. Dr. Aylward, Senior Advisor to Director General.
Yeah, just a very quick response. So recognizing this challenge, WHO, right at the very beginning of the pandemic, very early on, we established what we call our target product profiles that says this is the standards that a vaccine should hit. And these were published broadly. It's what all the vaccine manufacturers have been working toward. And as countries are assessing vaccines, they're looking at, do they hit these standards? And then we have also put in place, of course, to the specific question about what WHO is doing, we have a whole pre-qualification emergency use listing process that looks in detail at all of the data that companies generate as part of these trials to ensure that they meet the necessary standards. These standards, as well as the criteria, are published on our websites where, again, the general public can look and say, what are the kind of standards? How do we assure that these are hitting these standards? What is the process to get there? All of that is laid out very clearly, very transparently. And this aligns very, very closely as well with what we call the stringent regulatory authorities around the world are also using as they assess the vaccines also. So when you ask about the general public should have great confidence in products that have been looked at by stringent regulatory authorities and the WHO process, because it goes through all of those measures systematically. The efficacy, the safety, the quality of the product, but also the programmatic suitability to make sure that this is something that is going to suit the circumstances in which these are going to be used.
Ja, bingo, Bruce. say something very similar. Countries, and I think it's important that when citizens are looking to governments now and saying, well, we're not getting the vaccine, and there's vaccine in some countries, and governments have made choices. I mean, they've been looking at price and the profile of the product, the production capacity of the product, and their access to it because of that. And I think it's an important moment for us all. There are going to be many vaccines coming on stream at different times. Some will have different advantages over the others. Some could be used at higher temperatures, Bruce, and some will be produced in higher volumes. Countries will be more used to working with a single product over a long period of time. So where you may lose in a certain part of the early part, you may gain in speed and you may gain in effectiveness later. So I don't think we should be seeing this as a game of winners and losers right now. We're at the beginning. And yes, the products that are coming through now are in low volume. They're very expensive products and they're low volume. They've come through first, but other products will come through, we hope, early next year. So I think this idea of talking about good or bad vaccines or better or worse approaches, and we start to hold and judge governments against one another. I think governments, COVAX partners, have been negotiating in good faith with manufacturers to make the best deals they can against what Bruce has laid out very clearly, against things like the profile of the product, the production capacities, the state of data available about the product and its likely performance, and ultimately about the price of that product. These are complex decisions, and I think it could be very destructive for us all to turn this into some kind of nationalistic foot race to who does what. We all have to get there together. We simply have to finish this race in a line together. And someone getting there first doesn't necessarily help everybody else. So I think we're all going to have to just be a little bit patient and a little bit tolerant that things are going to move at slightly different paces in different situations, and we don't politicize this. And again, we've seen this again and again in this pandemic. Issues that should be about collective responsibility and moving forward together turned into comparisons and turned into he did good, she did bad, she did, and this is not the way, quite frankly, that we need to move forward right now. We need to move forward in solidarity to find these solutions. Science has delivered. Now we need solidarity to deliver the ultimate solution, which is to stop this virus transmitting and killing the people we love.
Science, Solidarity and Solutions. Next question, Bayram from Anadolu News Agency. Bayram.
Thank you, Tariq, for taking my question. My question for Mr. Antonio Vitorino, but Mr. Tedros can also add something on it. According to UN official figures, Turkey continues to host the largest number of refugees worldwide. Turkey currently hosts some 3.6 million registered Syrian refugees and 370,000 persons from other nationalities. Of course, Turkey had a lot of challenges during the COVID-19 pandemic, maybe more than any other country, as they host millions of migrants and refugees. So today, Mr. Vitorino, will you have a call to European or Western rich countries to open their borders to migrants, and to share the burden of Turkey? Thank you very much.
The answer is very easy. Absolutely. We think that there is a shared responsibility of the international community to support countries that have the responsibility of hosting large number of refugees, asylum seekers and migrants. The good news I have for you is that fortunately in most of the refugee and migrant camps all over the world, the virus has been contained. The number of casualties in camp settings, which was my worst nightmare, has fortunately been rather low, sometimes even lower than in the host communities. But that does not mean that there is no need for a specific approach to the vaccination when it comes to the people in the camps. Because the camps are, well, you cannot have social distance in the camps, let's be honest. People wear masks and that's very positive, but social distance is impossible. So the efforts of IOM and other UN partners, WHO, UNHCR, HCR and other agencies is precisely to deliver health support and health services to these populations and to help host countries in dealing with the challenge that represents guaranteeing that those migrants and refugees are safe, are screened, are traced, are quarantined, and now, beginning next year, are vaccinated. Thank you.
Thank you very much, Mr. Vitorino, for this. We will go to our next question. It comes from Adrian, who works for Medico. Adrian, I also think it's the first time for you to be with us. Adrian? Can you please unmute yourself, Adrian?
Buenos días.
Hello.
Se ha declarado.
In Mexico City, an emergency has been declared, as well as in other cities in the country, and there's been a high amount of infections and deaths. What has Mexico done to end up in this situation?
Can you hear me?
Yes, Adrian, I think we were able to hear your questions about Mexico and the latest situation in Mexico.
Hi, Maria may add, I don't have the direct Mexico numbers with me today, but we have spoken about Mexico in the last number of days, and Brazil and other countries in Central and South America, and we have seen worrying increases. In fact, Mexico, like other countries in North America, never really exited its first surge or first wave. It managed to get some degree of control, and the disease has surged again in many places. And we've seen that same phenomenon happen in other countries like Brazil as well, the United States. Over 3/4 of the cases, we're seeing globally now are occurring in the Americas. It's a very, very high and intense period there. And it really does come back to being able to implement all of the measures that are needed, having strong coordination and governance, having a do-it-all approach in terms of both public health and social measures, advice to people on wearing masks and personal hygiene, and having a very strong focus on surveillance and testing, and having a health system that can cope with the cases when they do occur. It's been tough for all countries, but where countries have not been able to implement a comprehensive strategy and sustain that over time, and gain the buy-in and support of their population and provide that support back to their population, it's been tough for many countries to get through their first and second surges or waves of this disease. We've predicted, we've said that here too. Vaccine is on the way. It is a source of great hope, and we should celebrate that vaccines are coming. But the next 3 to 6 months are going to be tough. Countries are currently have intense community transmission are likely for that transmission to intensify. Countries that have had good control on the disease may struggle to maintain that control in the disease, and you've seen that in a number of countries. Even in East Asian countries that have done well up to now, they are really having difficulties in containing certain, particularly urban outbreaks at the moment. So past success is no guarantee of future success. Past failure is no guarantee of future failure. It is really what you do now, what everyone does now. We have to bring vaccines in as a tool that puts an end to this virus, but the vaccines alone won't do it. And we don't have those vaccines at a level yet that they can actually affect the transmission dynamics for this organism. So Mexico is no different to other countries. Many, many countries are facing up a very serious mountain again at a very difficult time with the prospects for increased transmission. Other countries are maintaining their capacity to control the virus, and some are struggling even at that. We've been saying it here for a very long time, so at the risk of repeating ourselves again and again, there is no magic to this. There are no unicorns here. It is a very simple commitment to just doing the very simple and direct things that need to be done and continuing to do that. They're very hard miles. It's a very difficult thing to do. Sustaining government effort, sustaining cohesion, sustaining community compliance and participation. They sound easy. They're the hardest things to do in public health. The hardest things to do in public health. And we're sorting out the sciencey bits, but we're really not doing well at sorting out the social bits, the leadership bits, and the coordination and the support we need to our communities to be able to contain this virus. Maria, if you may wish to add anything, or...
Thanks, Mike. So just looking at the numbers, I mean, we are seeing an increasing number of cases being reported from Mexico over the last 3 weeks. We're seeing a stabilization of the deaths over the last 3 weeks, with more than 4,000 deaths being reported each week. When we look at the numbers, and what we're seeing from the data from Mexico is that there is detail that's being provided at the subnational level. And I think that's a really important factor. If you look at things at a national level, you miss the details of what is actually happening in terms of transmission in specific geographic locations. And if you have the systems in place, the surveillance in place, the testing in place, the data management in place, you can not only find the virus and take the public health actions to keep people safe in terms of isolation, clinical care, contact tracing, cluster investigation, supported quarantine, then you know, if you know where the virus is, you know how you can use your resources and your capacities to the best of their ability. And so if we look at some of the breakdown, we can see that there are differences in transmission based on different parts of the country. And so this is true for Mexico, but it's true for every other country. It's breaking down the problem into actionable interventions that you can be targeted, you could be tailored, and using the resources wisely. So it's not just about the comprehensive approach, it's about using that in the most appropriate way based on the situation that you have at hand. And we are seeing that. But unfortunately, we are seeing an increase in cases across Mexico, but you have the tools in hand right now that can turn it around. And I think that's what's really critical right now. Again, as Mike has said, and as the team keeps saying, we have vaccines and, more importantly, vaccination that is starting to come online, but it will take some time to reach everyone. And so please, know that there are tools that you have now. And each one of us has a role to play, as well as leaders at political levels or community leaders or youth leaders, to take the necessary steps to not only know where the virus is, but to take those necessary steps to lower your risk of exposure, which will lower your risk of infection. So stay the course, use the measures that you have at hand in the most appropriate way you can, and you will get through it.
Thank you very much, Dr. Van Kerkhove and Dr. Ryan, for this. Now we will go to Agence France Presse. We have Nina Larson with us. Nina?
Yes, hi. Thank you for taking my question. I wanted to ask you about the international mission going to China next month, which has been announced it's going to happen next month. Could you tell us specifically when the experts will go, if you have the dates, and where they'll be going in China, under what conditions they'll be working, if they'll be under Chinese supervision, and if they'll need to quarantine before starting work, which will obviously impact, I guess, how long they have to stay. Thank you.
Yeah, Maria can provide more of the details. We are planning. We still don't have a takeoff date because we're working on the logistics around visas and flights. But we do expect the team to leave in the first week of January. There will be quarantine arrangements. Obviously, we have to, as ever, we'll have to comply with whatever the arrangements are for risk management in travel and on arrival in China itself. The team will visit Wuhan. That's the purpose of the mission. Clearly, the team will pass through and by Beijing, as is the necessary part of any mission that's considered to be a joint approach. We will show good courtesy to our colleagues in China in doing that. But the purpose of the mission is to go to the original point at which human cases were detected, and that we fully expect to do that. The question regarding the team is a WHO team. It's a team of international experts who are of international renown, who will work with our Chinese colleagues. They will not be, as you say in quotes, supervised by Chinese officials. I sometimes wonder at the language that some of our journalistic colleagues use and how things tend to be characterized through the question, not through the answer that's given. We will operate as we would operate in any member state, at their invitation, with gratefulness for their support to that, and with the full intention of pursuing the scientific principles that this organisation has always stood for. And we will continue to do that and provide all the support necessary for the international team that we have brought together in order to find and learn more about the origin and source of this virus.
Many thanks, Dr. Ryan. So next question is from Radio France Internationale, Jérémy Lange. Jérémy? Jérémy, if you hear us, please unmute yourself. We don't have Jérémy now online, so let's go to Simon Ateba. Simon?
Yes, thank you for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. My question is about seriousness in Africa, and it goes to Dr. Tedros. Do you think the African continent continues to take COVID-19 seriously? And I know that Africa is not one country, 55 countries, 1.3 billion people, 2,000 languages. But it seems to me that the social distancing, use of masks and the rest is no more the way it was months ago. Thank you.
I can start. Yeah, Africa is a very diverse continent, and Simon, great that you, being from there, recognise that many don't. Tends to be seen as one amorphous continent, which never ceases to irritate me. The reality is that Africa is not out of the woods yet, and we've seen South Africa continue to battle higher numbers. We've seen countries around Eswatini, I think we've seen in Namibia, we've seen in Botswana, we've seen Southern Africa has had a continued issue. We've seen small, but the trajectory in West Africa, the trajectory in parts of East Africa is actually upwards, trajectory in South Africa. So while the absolute numbers may not be huge, the trajectory is worrying. So Africa does need, countries in Africa need to maintain their vigilance. There is no question about that. But it's also a very, very long road. And many people in Africa live in a situation where they have to work to live. They have to work to eat. And therefore there are more limited choices for people in that situation. They don't necessarily have government structures that can put aside trillions of dollars to pay people to stay at home, and therefore people don't have the same choices. I have seen a pretty high compliance with mask wearing and other stuff in Africa. We've seen some excellent examples of surveillance and investigation. Our colleagues in South Africa have been tracking the evolution of this virus and genetic variations and state-of-the-art work. And I keep saying that surveillance in Africa is probably, in terms of the ability to do contact tracing, some of the work done in Nigeria by Nigeria CDC is global, state-of-the-art work in Rwanda and other places. So Africa is actually showing the way in community engagement, showing the way in community-based approaches. It's showing the way in keeping this disease, as you said, Vitorino, in terms of migrants and in terms of refugee camps and other places, and remembering that the vast majority of migrants and refugees in the world are being hosted in countries who don't necessarily have resources that others do. And there are millions and millions of refugees and migrants hosted in Africa and on the African continent, and without the terrible complaints we hear from others about hosting hundreds or thousands. So from my perspective, yes, Africa is not out of the woods, but Africa is also leading on the leading edge of much of this response and showing the way for how you can deal with one of many emergencies at a single time. I think at one point last month, I think Sudan was dealing with 10 different epidemic emergencies at the same time. Imagine if that was the case in other countries, and doing it with a high level of quality. So there are, like there are in every country, there are things that we'd like to see more of, and very clearly Africa is not out of the woods, and there's every chance that things can get worse on the African continent. And therefore, it's really important that we also make sure that vaccines and other interventions, new diagnostics and new therapeutics are shared equitably across the world based on risk and on vulnerability. DG, you may wish to add.
No, thank you. I think the seriousness of Africa was clear from the start, Simon. Many countries, majority of them, started their actions as early as possible, their social measures and so on. You remember when many countries, when they didn't have even any cases, they were taking serious measures. I think that prevented from serious problems happening in many countries in the continent. And you can see actually the situation not only from the specific country preparedness, early preparedness, but the continental action they were taking. I remember having a meeting with the ministers of health in February, March, preparing the continental strategy. And the political leaders, the AU Commission, Moussa Faki, and the current president of the African Union, the chair of the African Union, heads of state, also, President Ramaphosa coordinating the overall response. So not only the individual, the immediate action or early action by individual countries, but the continental strategy and the coordination of the leaders to implement the continental strategy. I think that really helped. If you see the countries that are contributing the most, 12 countries globally, none of them is from Africa in terms of cases or in terms of deaths. Of course, there could be not only the early response, but there could be other reasons to explain this. But we believe that Africa had really done its best. And the seriousness you said is there, and we hope that will continue. As Mike said, there is hope, good hope now for vaccines, and that's additional tool. But all countries should continue to do the basics and follow a comprehensive approach in order to defeat the pandemic. So because of vaccines, which are still rolling out now, we shouldn't lower our guard, and we should continue to be very vigilant and implement all the measures we need to implement based on the toolbox that we have been implementing. Thank you.
Thank you very much, Dr. Tedros. We received a question. You mentioned South Africa received a question about news from South African scientists on the new variant of the virus. So maybe Dr. Van Kerkhove can comment on that, please.
Yes, sure. So thanks, Tarek, for the question. So yes, we are aware that South African researchers have identified some virus variants from sequencing of patients across the country. And I should first and foremost say that South Africa has worked incredibly hard to increase sequencing capacity across the country, which is really commendable. And we are seeing increasing in the ability of sequencing all over the world. So that's first and foremost, that's really important. So yes, they have, we're in touch with researchers and scientists from South Africa who've identified some virus variants. What they're doing right now, the variants have mutations in them, and as you know, this is a virus that mutates. All viruses mutate, all viruses change over time, and these mutations are expected. But having the ability to sequence will allow them to actually look at those changes. So what they're doing right now, and we are working with them with our SARS-CoV-2 virus evolution working group, they're growing the virus in the country, and they're working with researchers to determine any changes in the behavior of the virus itself in terms of transmission. Does this virus transmit more easily than the others? Are there any differences in severity? Are there any differences in the ability of a person who is infected with these variants to develop antibodies? And are there any differences in the diagnostics or therapeutics or vaccines? So far, we have no indication that there are any changes in the virus's behavior, but these studies are underway. And so that's what's really important, is that South African researchers, as well as researchers in the UK, because you know there are other mutations that are identified in the UK, there have been mutations identified in other countries. There's a system in place, there's a process in place to evaluate each one of these mutations, each one of these variants, so that we understand what are their importance in terms of the virus's behavior. And so these are studies that take some time to be conducted in the lab. And we have the mechanisms, the trust, the collaborations that are in place with the researchers in South Africa and in other countries to work on to determine if there are changes and what those changes mean. So as soon as we learn anything about this, we will let you know. South Africa had a press conference, I believe, at the same time as we were doing this press conference here, providing the information openly, and this is a good sign. You know, this is what we need to see. But you know, the longer this virus, the more opportunity this virus has to spread, the more opportunities this virus has to change. So it's really important that we do everything that we can to minimize the spread now with the tools we have. We can't emphasize that enough. So we thank our colleagues in South Africa, as well as colleagues in the UK and Denmark, who alerted us to mutations that they've identified and who are carrying out the scientific studies to help us understand the implications of these.
And maybe a shout out to those who work in the likes of GenBank and GISAID and others who accept and post all of these sequences as well. So and thanks to those who do continue to do that. Keeping this information in the public domain is really important, and having all scientific eyes on that to look for any changes that are significant. It's really important. This is a collective process. This is collective intelligence that's applied to a complex problem, and it requires a lot of people to have input. So it's great to see this kind of collective intelligence put to work.
Many thanks. We are getting closer to the hour, so let's try one or eventually two questions. Stephanie from Reuters. Stephanie. Stephanie, you will need to unmute yourself.
Sorry, I had my hand up to ask about the same issue about the South African variant, which Maria has already addressed. So unless she has something more to say about it, I think we're good. Thank you.
Okay, well, that's very good that we managed to answer your question in advance. And with this, we will conclude today's press briefing. Big thanks to our guests, Mr. Antonio Vitorino, Director General of the IOM, and Jacqueline Vickers from Migration Health Division of IOM, and to our WHO guests. Last word, as always, goes to Dr. Tedros.
Thank you. You have said what I wanted to say, to appreciate my fratello, DG Vitorino, and also Director Jacqueline for joining us today, and look forward to working even more closely. And thank you for your partnership and friendship. Grazie mille. And thank you also to all who have joined us today, and bon weekend. See you next week.
Dr. Schwell, you've advocated for vitamin D as a potential way to prevent COVID-19 infections, to prevent severe COVID-19 infections. You've talked about this for a few months now. And over the past several months, The evidence continues to grow. There's more and more publications in peer-reviewed medical journals about the possible connection between vitamin D and COVID-19. So you've put together a presentation for us. Tell us about what your presentation is all about.
Yeah, thanks, Kyle. So we've been talking about vitamin D as a potential therapeutic agent for COVID-19 since March. And since that time, a lot of other people infections, for instance, influenza, and what was the data there? And then we look at the epidemiological evidence for vitamin D as a therapeutic agent in COVID-19, and then finally moving along to actual cases, hospitalizations, and then we build up with that hierarchy of evidence with vitamin D and COVID-19 to randomize placebo-controlled trials, which of course are the gold standard for therapeutics.
Okay, so let's talk about vitamin D. The first thing you've got to understand is that vitamin D is not just a vitamin. Vitamin D is actually a hormone. And if you notice here by the structure, you'll see that it is a steroid hormone, which means it can go into the nucleus. It can go through membranes and make effective changes. And specifically, the vitamin D receptor is a member of this nuclear receptor steroid hormone superfamily. And so as you can see here, we have vitamin D going through the membrane and affecting a binding to the receptor, and then it actually goes into the nucleus where it can affect transcriptional change. This is really important. So this is not just some vitamin that you need to supplement with. This is actually a hormone that changes the way your cells in the body actually behave.
Is this idea unique to vitamin D, or does this happen with other vitamins? And in addition to that, what are some of the main differences between a vitamin and a hormone?
Good question. So, a vitamin is actually a shortened version of a vital amine. Vital meaning you need it to live, and an amine is a type of chemical compound. Vitamin D is not even an amine. Of course, it's vital, but it's not as if you need a certain amount of this substance to just keep the body going and doing what it needs to do. No, I mean, vitamin D is so much more complex than that. We used to think that vitamin D was just involved in calcium regulation, and that is certainly true. There's no question about that. But vitamin D is so much more than that. It's a fat-soluble vitamin, which means it can pass through membranes without any problem. It doesn't need to be regulated. It can bind with the receptor and go directly into the cellular portion of the nucleus, in fact, and actually cause or prevent transcription of RNA. And we've seen that there are vitamin D receptors in numerous cell types, including the cell types of the immune system. So in that sense, it is a hormone, but in another sense, you can only produce enough of this if you have enough sunlight, or if you're taking this in a dietary supplement form. You can't make this without sunlight or getting a dietary form. So in that sense, it is vital that you have it, and in the loose sense, it is a vitamin. So to get to your second question about hormones and vitamins, hormones are something that the body uses to signal and to make effect changes throughout the body. For instance, insulin is a hormone. Cortisol is a hormone. These things circulate through the body, and they have different effects on different target tissues. Vitamins are more along the lines of something that you need as a cofactor or something else to get something to work. And so in that sense, vitamin D is certainly a vitamin because your body needs it in order to live. But in another sense, it's so much more than just a vitamin.
So how do you get this vitamin D? Now, I know this looks a little complicated, but bear with me. The key that you need to understand is that it's the 1,25-dihydroxy vitamin D that's the active form. And it says here that it does come from the kidneys. But in fact, we now know that the rate-limiting step that puts that one hydroxyl group on is not just in the kidneys, it's also in the immune cells. And it can actually put that on and have effective change in your immune cells themselves. So let's talk a little bit about how this happens. So there's basically two ways you can get vitamin D into your diet. You can either eat it through a supplementation, swallow it. You can take pills. It's also found in fish oil, certain types of mushrooms, egg yolks, and also red meat. or the majority of people get vitamin D into their system from the sun. Why is that? Because ultraviolet B radiation penetrates down deep into the dermis, where this cholesterol derivative is converted into pre-vitamin D3 and then finally into vitamin D. Now, that vitamin D3, after it's produced by the sun, goes to the liver and